talk what it is, how it happens, what's pathophysiology. We'll talk about how to diagnose pulmonary embolism with thromboembolic disease. We'll talk about basically diagnostic and treatment, and we're going to talk about anyways, guidelines associated with it. So you just have to understand in your circulation, you have your left-sided and right-sided circulation. Your left side, from left ventricle, cardiac output perfuses the body, right? The brain goes down, kidneys, body, and then comes back. Venous circulation comes into the right side of your body. The right side of your body comes into the right, the right atrium, goes down into the right ventricle, and then pumps into your lungs, right? And your lungs oxygenate and deoxygenate the blood. So your lungs also do something else. They work as a filter for your body, in the sense that if your blood is clotting or abnormal clotting, it will actually filter out these blood clots. And we think this is part of what it is. So they work as a filter, and in that sense, if you have any thrombotic event in your body, it's mostly going to be on your right side, because it's usually in the venous side, because it's a slower side, and it will come into your lungs. So if a blood clot forms, usually on the venous side, it's going to come into your lungs for the most part. So we call that an embolic event. So pulmonary embolism basically is one of the life-threatening causes of chest pain. You're going to have chest pain. You need to understand PEs, and I'll explain to you thromboembolism in general, so you understand why PEs happen. And it's one of the reasons people come in with chest pain, shortness of breath, or wheezing. Pulmonary embolism, actually, the most common type is thromboembolic, which means you have abnormal thrombosis of your blood, and then it will move into your lungs from a DVT. This is the most common type. But it can happen from other things, pulmonary embolism. It can happen from fat. We see that in major trauma, in people who have fractures, like especially long bone fractures. We see that in severe burns. We see that in people who get fat therapy, ultralipid therapy for like toxins. So there's a lot of things in called fat. We see people who get liposuction can get fat embolisms as well. Amniotic fluid embolism, we see that as well in people in peripartum who are women who are delivering. Some of the amniotic fluid will actually escape into the venous circulation, and it will cause an embolic episode. We see from tumors, especially renal cell carcinoma, can do that. They can actually break off pieces of the tumor and go into your lungs. Air embolism, we see that in healthcare settings when people are put in IVs incorrectly and inject, or put in a central line incorrectly and inject air that can kill patients. We also see it in patients who are diving and diving injuries as well, can escape from the lungs into the venous circulation. And then we see it also in IV drug users because they're injecting drugs, they can inject foreign material into the venous circulation. All this are embolic events, but thromboembolic, when we say PE, we're talking about a fulminant, a thromboembolic event in venous thrombosis, okay? So like I said, generally if you say you have a PE thromboembolic, we're talking about a DVT. It's interchangeable process. So the risk for PE are the same as the risk for a DVT, right? It's the same disease, it's just progression of the same disease, okay? So how does DVTs form? Well, basically this gentleman is Virtue. You've probably studied him in physiology. Basically, he described why does blood clot abnormally. Well, he says that basically the blood will clot abnormally because there's something wrong in the vessels and the flow is abnormal. There's turbulent flow in the vessels. Or the blood is static and not moving because blood needs to be circulated all the time, and that will cause to clot. Or there's an abnormality in the blood itself, it's hypercoagulable, it's prone to clot. Those are the three reasons people form blood clots, okay? So under this understanding, you can understand why people form thrombosis in their lower extremities, okay, or in gait peaks, okay? So we talk about the thromboembolic events, we talk about other factors. So people, there are risk factors, people who form thrombosis. Basically, if they're obese, they're overweight and metabolic syndrome, people who smoke, all these things, people with hypertension, people with dyslipidemia, people with high cholesterol, these are people who are more predisposed to having blood clots. There's some things that are non-modifiable. The older you get, the more likely you are to have it. If you have hypertension, the more likely to have it. Family history, the more likely to have it. Recent surgery, and that's probably from stasis, abnormal vessels, people with heart failure, people with abnormal lung disease, infections, acute inflammation, all that will predispose you to have thromboembolic event from inflammatory cascade. Travel, we're not sure why. We think that long haul travel or probably from stasis and poor movement. But it's not clearly just that. There's probably something else with the altitude that makes a difference as well. All contraceptives and estrogens, all of them predispose you to thromboembolic events. These are important things to talk about. Hormone replacement therapy for the same reason. And then any mechanical devices or anything abnormal within the vessels, like pacemakers, indwelling catheters, all these things will cause turbulent flow and will cause increased thrombosis. And then obviously genetics, right? If you have protein C, protein S deficiency, and phospholipid antibody, all these things will cause your blood to clot more regularly. Make sense? Yes. So we're talking about PE specifically here. So what's the presentation of pulmonary embolism? Well, mostly chest pain. But the problem is that chest pain is usually non-specific chest pain. We talk about the most commonly type, the most specific is if it's pleuritic chest pain. But a lot of these patients actually have non-specific chest pain. They often come in with dyspnea, they have a sensation of trouble breathing. Some of them will just come in with anxiety, some of them will come in with coughs, and some of them will just come in cardiac arrest. They will be fine 1 second, they'll just have cardiac arrest, and it's from a pulmonary embolism because of the big pulmonary embolism. So the point is to say the problem with, unlike coronary artery disease where you have a typical presentation of ischemia, chest pain, exertional, a lot of patients with pulmonary embolism will have non-specific presentation. So the presentation is not clearly pleuritic chest pain with hemoptysis and a DVT. A lot of them come in with non-specific chest pain, but they have risk factors. So it's mostly based on cardiopulmonary presentation with risk factors. Okay, we'll talk about that. So the signs, they may have tachycardia, tachypnea, they may have some fevers without abnormal heart sounds, hemoptysis, and then signs of a DVT. If something comes in with chest pain, have a DVT, it's a PE by definition. You don't need to think about it twice. Okay? But a lot of times you don't have that. That's the problem. So most of these patients, so how do we think about, when we think about PE, it's usually when we have someone with cardiorespiratory presentation, but we cannot explain it. It's not heart failure, it's not pneumonia, it's not a viral infection, it's not musculoskeletal, it's not ischemic chest pain, then we think about PEs, because they're very difficult to diagnose. Most of these patients will have normal blood tests. You've heard of D-dimers? D-dimers, you know what it is?
Increasing case of...
What is it? It's D-dimer measures fibrin degradation. Fibrin is the last part of your coagulation profile. When you're forming a blood clot anywhere, if you have a cut, whatever you're forming a clot, you form fibrin. So when you have a lot of fibrin and your body starts breaking down, your body breaks down the fibrin, so this measures the fibrin degradation. So this suggests that you may have large blood burden. The problem with D-dimers is that a lot of people at baseline have them elevated. Like 40% of people will have a positive or abnormally a high D-dimer at baseline without disease. And it increases for many things, from chronic pulmonary disease, chronic cardiac disease, chronic renal disease. And some people just have it high at baseline for no reason. So it's not specific at all, but it's very sensitive. So most patients with blood clots will have it high. Rarely will you have a blood clot, but not have it high. Okay, does that make sense? Yeah. Okay. It's highly sensitive, but non-specific. Okay, it's important to understand that. And it's been validated for use in emergency settings, like in an emergency department, but not inpatient. So if you're in the hospital for 2 weeks and then you take a D-dimer, it's high, it's not really that useful to tell you, does this person have a pulmonary embolism or not. People use it that way, but it doesn't work that way. And it's a dichotomous test. It's positive or negative. The number actually doesn't matter. The number itself, some people will say, oh, I'll repeat it, I'll measure it. It doesn't work that way. It doesn't tell you anything useful. If it's positive, it's positive. If it's negative, it's negative. That's the only way it's been designed to use, okay? And it has sensitivity of 95%. So 95% of patients will have thromboembolic events. You can capture that with a D-dimer that's positive. But 5% of patients will have a thromboembolic event and you'll not be able to capture that. Do you understand that? So you will have people have normal D-dimers but have PE or DVT.
Does it exclude PE?
It doesn't definitively exclude PE. It just lowers the risk of it very much, okay? So it's a screening test.
But it's good to do CT, right? CT.
We'll talk about it. It's important. So we use it to say somebody is very unlikely to have a thromboembolic event and can help us decide not to do advanced imaging. But if it's positive, it doesn't tell us much because we know a lot of people have it, okay? It just tells us, oh no, maybe I should continue testing if it's positive, if I'm thinking about it, okay? Just remember, a lot of people will have it high at baseline. So ECGs, so patients again, we're talking about PEs, like I said, they have a lot of symptoms they can come in with, and sometimes they come in with very few symptoms. Mostly, so we'll talk about the different testings that we do for like
I didn't understand that.
We do ECGs for either chest pain. Most patients with pulmonary embolism in ECG, they'll have non-specific findings. Some mild sinus tachycardia, some T-wave inversions. A lot of them have normal ECGs, but mostly sinus tachycardia is what you'll see in the patients. There is specific findings for PEs. Is like an S1, Q3, Q3. You can look it up. We like asking about it in the exam. It's very specific, but I think less than 15 or 10% of patients, even less, with confirmed PEs have this finding. So a lot of patients who have PEs will not have this finding. So you cannot depend on it. But if it's there, it's useful. Okay. And then there's specific things we see also for PEs like right-sided heart strain. That's mostly the large pulmonary embolism because it's causing right bundle branch block and right heart strain. And they can come in with AFib and aflutter. We see SVTs a lot with people with pulmonary embolism. So the chest X-ray is useful in pulmonary embolism because usually what we expect to see is nothing. It should be normal. If somebody comes in with shortness of breath, dyspnea, palpitations, whatever, cardiac arrest, and then you have a normal X-ray, you have to think, oh, could this be a PE? But if they come in and you get a chest X-ray and you see heart failure, you see pneumonia, you see pneumothorax, then you have an explanation, right? So the chest X-ray is helpful that if it's normal, it will make you worry about it, yes. So the point is to say, there are specific chest X-ray findings in PE that we do see. They're very rare, but you need to know them because they like asking about them in exams. There's like a Westmark sign, which is focal oligemia, which basically means there's an area where there's supposed to be lung vasculature, the black part. You just don't see it anymore because there's no vessels are blocked. It's very rare to see. And then a wedge, and then infarction of the lung itself, sometimes called the Hampton hump. It basically looks like a pizza. I'll show you a picture of it. Basically, there's an infarction of that area of the lung. Yeah, and then sometimes we see some very subtle findings like right-sided enlargement, but that's very difficult to see. So how do we diagnose pulmonary embolism? Well, this is how we diagnose it. The gold standard test. Like I said, for asthma, the gold standard test is PFTs. We don't do that because it's so common, but PEs, no. Unfortunately, the only way to diagnose a PE is with the gold standard testing. So what we do is spiral CT or CT pulmonary angiography. And it's a CT that's timed to your right ventricular emptying so we can see contrast inside your pulmonary arteries, okay? It's not a CT chest. It's not a contrast CT chest. It's a CT it's a spiral CT, and it's timed at a specific time because you can obviously get a CT of the chest with contrast, but if it's filling at the wrong time, you're not going to see the pulmonary arteries and you're not going to see where the pulmonary embolism exists. Okay, so it's useful because it will physically see if there's a clot or basically an obstruction. And it also can find other causes that we don't see on X-rays. We'll see pneumonia sometimes that we miss. We'll see electrolysis. It'll see pneumothorax. So these are other findings that can explain the symptoms that we often will miss on chest X-ray. Make sense? Yeah. So this is the gold standard test. So this is a definitive test to say yes, you have it, no, you don't. Okay? Because everything else is not. We cannot rule out the disease. All right?
Doctor,
Hey,
how do we diagnose with pregnant women?
with this test.
CT?
The CT also does other things. It can tell you the severity of the pulmonary embolism, because a lot of pulmonary embolisms are not severe and you can treat them and send them home. They can go home. Some of them need to be admitted and some of them need to go to the ICU. So we need to decide how severe is this disease. So it can tell you if the right ventricle is dilated. It can tell you how big is the thrombus. Because it makes a difference if the thrombus is in a small subsegment in the pulmonary artery versus if it's in the main pulmonary artery. Okay. Yeah. And then it can tell you for people if there's acute or chronic thrombi as well. And then these CTs can also use it to do a venous phase in the legs, and you can see when the contrast comes back, you can look for DVTs with them as well. And it can tell you if they have acute signs of heart failure on the CTPE, because the right ventricle starts to dilate, and it's a bad sign. Also a picture. So this is a CT pulmonary angiography. So this is the aorta. This is the pulmonary arteries. So here, this is the left mainstem bronchus, left pulmonary artery. And you'll see here, this contrast is supposed to keep going, but it's not because this is a blockage. Okay, so thromboid blockage. And then this is the heart itself of the same SAT, I guess. So this is the left ventricle, right ventricle. The left ventricle is supposed to be 60% bigger than the right, but here the right ventricle is dilated. It's bigger than the left. So this is big PE that's causing the ventricle to dilate. So this guy is very sick. You know, this is already a big burden, and this is a big burden of disease. So this is how it's a useful test as well as not just diagnostic, and it will tell you how severe the disease is. Okay, make sense? So what else can we do to diagnose PEs? Well, you know, sometimes, like I said, you don't need the CT because let's say someone has a DVT. If you confirm a DVT, if someone comes in with chest pain and you do a Doppler of the legs and they have a thrombus in their legs, and it's done. That's a PE by definition, right? You don't need to do any more testing because the treatment's the same for both. Make sense? Yeah? But if you do a Doppler, it's negative and they still have symptoms and you don't know, right? And the point is you need to make that definitive diagnosis because the treatment has a lot of side effects. You can't just put everyone on treatment. You have to make sure that they do have the disease or not. There's something called a BQ scan you sometimes see. It's a radioisotope scan where they put a radioisotope in the air and they put it in and they tag it to your RBCs and they give it to you and they see where is the radioisotope in the lungs versus where it is in the blood. And if there's an area where it's in the lungs but not in the blood, that tells you that there's no perfusion there. So that is a BQ mismatch. So that tells you that there's probably a pulmonary embolism. Okay, you'll see it sometimes they do it in hospitals. They use it for prognostication, but it's rarely used for PEs now. We don't use it as much because the CTs have gotten very advanced and very quick, and this takes a long time, and it's difficult to set up. It needs a lot of technical ability to read it. Pulmonary angiography, conventional pulmonary angiography is where they stick a wire into your pulmonary artery and they shoot, just like a coronary angiography, they'll shoot contrast into the pulmonary artery. Can be used to diagnose PEs as well. We don't do that. Obviously, it's done in interventional radiology, and they do it if you're going to do a thrombectomy, if you're going to try to remove the large thrombus, like the interventional radiologist will do that. Okay? But it can diagnose pulmonary embolism. And then contrast venography, which is just a venous phase of the contrast to look for DVTs as well. In some patients who are very difficult to assess, we can do that. You can't do a Doppler, they're super morbid obese, or they're already getting a CT, you can do that as well. So, because you asked, I think we can just talk about that for a second. We used to think that, because like I said, pregnancy obviously is a risk factor for DVTs and PEs. Gravid uterus compressing the inferior vena cava, decreased urinary return, prothrombotic state with pregnancy anyways, and the increased hormones. So we used to actually try to do BQ scans for these patients, but we found that it's probably even more radiation for these women. And unless you have a DVT, that's usually what happens with patients with a pregnancy and worried about a PE. We do a DVT study. If the DVT study is negative, we'll do a CT, spiral CT. Because the spiral CTs are definitive, it's one test. The BQ scan often will give us equivocal findings, then we're going to have to get the CT anyways, so we don't do this anymore. And it's not less radiation. And actually, we're not worried about the radiation to the fetus, we're more worried about the radiation to the mother herself, more to the breast tissue, because it's rapidly proliferating tissue in the breast while the woman's pregnant. So we put shields on, more importantly than the baby's, the chest itself of the mom. The baby's exposure to radiation is likely not harmful, especially at full term. There is very small increases in chances of cancer throughout your life if you're exposed to radiation as a fetus. It's very minimal. Obviously, if we miss a PE and you die, that's not going to help you or your mom. So that's why we'll just do a CT for these patients. No other way. If the DVT study is negative and you still think a PE is likely the cause, then you're going to do a CT of these patients. Obviously, that's after everything else is negative. There's no pneumonia, there's no heart failure, you did a chest x-ray, it was normal. You can't explain the symptoms, so it's very likely, okay? So, differential diagnosis of pulmonary embolism. Well, it's a lot, right? That's the problem. Anxiety, pleurisy, which is inflammation after viral infection, costochondritis is a cartilage inflammation, pneumonia, bronchitis, myocardial infarction, pericarditis. It's a lot of things. Heart failure, pulmonary hypertension, dissection. There's a million reasons. GERD. So many reasons people come in with chest pain, shortness of breath, palpitation. So the point is, history and physical is the most important thing about these patients. You have to do a very thorough history and physical. We found that the problem is that a lot of people we still won't be able to. So that's why we developed scoring systems, and you'll see these systems with a lot being used now. And these scoring systems are used to risk stratify patients, and it helps you incorporate your D-dimer testing into your algorithm, so you know who needs a CT and you can just do a D-dimer test and who doesn't even need a D-dimer test, okay? Because the problem is you do D-dimers for everyone, 40% of people have positive D-dimers. So you're not going to scan 40% of people. It's a lot of CTs. And at the same time, 5% of patients, even with a positive D-dimer, a negative D-dimer, are going to have them. So who are patients who the D-dimer is not appropriate for? So it helps us decide who should we scan. That's what these tests are for, okay? It helps us decide who needs the definitive test, you know? If someone comes in and tells you, I have protein C deficiency, I've had DVTs in the past, I've had PEs in the past, and I stopped my blood thinners for like the last, 2 years, and he comes in with chest pain, thoracic chest pain. It doesn't matter what the D-dimer is. It doesn't matter what anything. You're gonna assume he has a PE, right? So it's not gonna change your post-test probability, right? But most people are not like that. Most people are gonna exist with some risk factors and some symptoms. So these are what the scoring systems are. So the most common one is the Wills scoring system. There's many. But the most common in North American one is the Wills scoring system, and it uses a combination of risk factors and symptoms and says how much does this increase the likelihood of PE? And if the likelihood is high enough, then it says, okay, then this patient needs a CT. If the likelihood is moderate, then it says you can D-dimer is enough. If the D-dimer is negative, you can stop, okay? And if the likelihood is very low, then we have another scoring system that says don't even do a D-dimer, okay? Does that make sense?
Yes.
Assuming you think it's PE. It doesn't make sense if someone has an pneumonia and you try to do this on them. That doesn't make sense. It's only if you think PE is likely in this patient. Make sense? Yeah. Okay, so that's signs of the DVT. Basically, now we don't use it. It's a dichotomized system. To moderate to high or low. If you're low, we do a D-dimer. If you're high, the D-dimer is not enough, we do a CTP basically for the Wills. You don't need to know the specifics, you just need to know what it is, okay? If you have any alternative diagnosis related to, you can explain it, then it increases. No alternative diagnosis, then you're already almost at a moderate. If you have any other finding plus this, then you need a CTP anyway. But if everything is negative, but you don't have a diagnosis, anything other than nothing else that can explain the symptoms, then a D-dimer would be enough. If the D-dimer is negative, you can stop. Does that kind of make sense?
Yes.
You get that? Okay. Hemoptysis, immobilization, whatever. Cancer that's active, makes sense. This is the Geneva score. Again, another scoring system suggests how to do CTs or not, just to know that they exist. And then this is a PERC rule. This is a rule that you'll hear also used with the audit. It's a rule used to say, does this patient even need a D-dimer, Because like I said, a lot of patients, if you just send D-dimers on everyone, a lot of them come back positive to formal. You'll have to do CTs for these patients. But this one says no. This says this patient's so low risk, you don't do a D-dimer, it's enough. Okay? Further risk stratifies. So usually your low risk Wills, put low risk here, where D-dimer is indicated. Then you decide, oh no, I'm going to do a PERC rule, and then if this is negative, I'm not even going to do a D-dimer. I can send you home. Make sense? So disease severity is important. Most PEs can be treated as an outpatient now that we're finding. A lot of people have PEs, they have thromboembolic. So we kind of categorize them into moderate, moderate, massive, submassive, and then PEs, basically. So massive PE is a PE that basically kills you, or is about to kill you. It's just as simple. There's a specific criteria cut off for it, basically systolic less than 90, or cardiac arrest, basically. So if it causes shock, or it causes cardiac arrest, then it's a massive PE, okay? By definition. Anyway, so these patients obviously all need to be admitted because they're about to die or have died. And then submassive PEs are PEs that are not causing hypertension or shock, but are causing end organ dysfunction and often will progress into massive PEs. So all these patients need to be admitted as well. They usually need to be admitted to high acuity settings, like that monitored setting. These patients usually have signs of ischemia of the heart, they have high troponin, they have ECG findings, they have significant hypoxia, significant tachycardia. So they have signs that their body is working physiologically because of this PE, okay? They're at risk of dying. But anyways, there's a lot of ways of treating them. So most patients have small or subsegmental PEs. Usually they come in with whatever symptoms, and they have their troponins are normal, their ECGs are not impressive, they're not hypoxic, and so they're stable in every way, but they have these symptoms. So these patients can be treated with outpatient anticoagulation. We don't need to admit these patients. Sometimes we still do because, psychosocial, MAFI follow-up, you can't, عايش في العدوى الدين ما عنده access to medical care, whatever. He has chronic comorbidities, he's old, he's not going to be able to take his medication. But now, because we have very good anticoagulation that can work immediately, we don't need to admit a lot of these patients. So we just continue to start with the emergency department. And why they had the DVT or PE generally is not that important in the emergency department. That can be figured out as an outpatient. So these are the most patients. So there's also scoring systems that tell us how severe is this PE. Should this patient be discharged? Should this patient be admitted? Should this patient go to the ICU? And basically they're old, they have cancer, whatever. They have cardiopulmonary disease, they have low blood pressure. These are all suggestions these patients should go admitted or go to ICU setting. Okay. So what are the complications of PEs? Well, they can have complications other than acute complications, which is cardiovascular collapse and death. But they can have some long-term complications. You can get pulmonary infarction where you have part of your lung stops working. Anyways, it's not common, but you see it. You have fever, leukocytosis, whatever. That's one of the complications. And it's the best way to treat pulmonary embolisms are to prevent it. So I'm just going to talk about reversible causes, obviously. Because we talk about, and I'm going to tell you about this, for DVTs and PEs, we say, was this PE, was there clearly a trigger or non-trigger? So if you get surgery and then you were put in a cast, you got this running in the cast and you get a PE or DVT, then we know what the trigger is, right? If you're like a young lady and you're taking OCPs and you start smoking, then that's actually a trigger, and you get DVT, then it's triggered, because we know both these things will increase your risk factors. So some of them are modifiable, some aren't. And it's important for long-term therapy, because if you have a modifiable risk factor, then we can put you on short-term therapy and we can stop it. But if you have non-modifiable risk factor, you have protein C deficiency, you get a PE, then you're probably going to be on anticoagulation for life. So the mainstay treatment for PE or DVTs is acutely is anticoagulation. Understand that anticoagulation does not, people misunderstand, does not break down DVTs or PEs. Your body will break it down. It breaks blood clots normally. It prevents progression, best. It prevents you from dying from this or this happening again. That's the whole point of anticoagulation, okay? So same for upper lower. There's multiple forms of anticoagulation. In the hospital we use heparins, low molecular weight heparins or conventional heparin as an infusion. But mostly now it's been replaced by oral anticoagulants. Rivaroxaban, apixaban, whatever. There are 10A inhibitors for the most part. They work immediately, they're very quick. We used to use warfarin in the past. The problem with warfarin is that it takes 3 days to work. It takes 3 days to get therapeutic. And then actually when you first give warfarin, it actually activates your procoagulant factor. So you actually can get thrombosis when you first get it. So we have to put you on heparin infusion first. And then we have to put the warfarin, then it takes 3 days. We have to bridge you. So warfarin is complicated. But now with these direct acting anticoagulants, you don't need that. They work immediately, work within a few hours. So we give you a pill and we send you home. You don't need to stay in hospital if you have low risk PE or DVT. Okay, does that make sense? But again, anticoagulation prevents progression and recurrence, does not break down the clots. So who are the patients we want to break down the clots? Yeah, so these are only for massive PEs, basically. We know for a fact that if your heart stops from a pulmonary embolism or you're in shock from pulmonary embolism, then we want to break down that clots and give you a thrombolytic agent. The problem, obviously, with these agents, just like we give them for MIs and we give them for strokes, is they have significant chances of bleeding. I can give it to you and then you're just going to start bleeding till you die or bleed in your brain and die. So you have to pick the right patients. Generally, these patients are usually younger who get these diseases, so they're usually not, So if somebody, you'll see them a lot come in cardiac arrest, and people are like, I don't know why a young patient came in cardiac arrest. A lot of times they'll give them alteplase because they think that a PE would have caused it. Does that make sense? Yeah. So we all exclusively give it in massive PEs. Sometimes in submassive PEs where the patient is, he's not yet in shock, but he's looking sick, he's getting worse, he's more tachycardic, more tachypnic. His blood pressure is not less than 90, but getting lower. His lactate's coming. We'll give them again because they're going into shock. So it's not black and white. But for these, if they're in cardiac arrest or in shock, they clearly need it. Okay. For everyone else, it's just anticoagulation, right? Duration, like I said, provoked or unprovoked. So if it's provoked, you have whatever cast. You're smoking, taking cigarettes, whatever. If you can reverse the cause, then you can put the anticoagulation for 6 months, usually for most patients. But if it's unprovoked and recurrent, then it probably needs to be for life. All right? Makes sense, right? IVC filter. You've heard of IVC filters? So IVC filters, some patients, you can't anticoagulate them, whatever. He has cancer, he has a brain tumor, you put him on blood thinners, he's going to bleed in his brain tumor, he's bled in his brain tumor before, or he has recurrent GI bleeds. So basically these patients, what we do is we put a filter in their vena cava. This filter captures blood clots that come from your DVTs, right? I said the DVTs are the causes of PEs, right? So they have to go through your inferior vena cava to reach your lungs, aslan. From IVC to get into right pulmonary artery. Anyways, so these capture blood clots. So you see some patients will get these. You just need to know that it exists. Basically, we give to patients who cannot anticoagulate and they have DVTs and PEs, and they're high risk. There's not been proven to save people's lives, but it decreases the frequency and occurrence of PEs in these patients. Okay, so you just understand, and they're retrievable. You put them in by interventional radiology, and they can remove them once the cause is reversed, assuming it can be reversed. All right. So remember that you think about PEs in patients who have cardiorespiratory symptoms where you cannot explain them. That's what you should think about it. The only time you get thrombolytics is for massive PEs. You can use IVC filters. There's limited evidence. You just need to know what it is, and you'll hear people talk about it for patients who need anticoagulation but can't get it and are having DVTs and PEs. And most patients now with PEs or DVTs can be treated on oral anticoagulation symptom. We don't need to admit these patients. Okay.